Good afternoon, everyone. Welcome to today's
Good afternoon.
webinar. Good afternoon. In the interest of time, I think let's start and people will join us. My name is Gladys Mirugi-Mukundi from the Dullah Omar Institute. Thank you for joining us in this important conversation today. Today's webinar on COVID-19 vaccines and human rights challenges is hosted by the Dullah Omar Institute, namely the Socio-Economic Rights Project and the Applied Constitutional Study Laboratory. The webinar seeks to address issues such as accessibility, cost of vaccines, categories of people to prioritize and how to ensure equitable distributions of the vaccine, as well as safety and whether vaccines should be made compulsory. We are privileged to have three panelists in this conversation this afternoon. And I'd like to invite our first panelist who will give us opening remarks, Dr. Tlaleng Mofokeng, the UN Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of health. Welcome, Doctor. Over to you.
Thank you so much for the kind introduction this afternoon and for the invitation to join all of you and the Institute as you do this very important work at this very difficult time. And I do hope that everyone remains safe and well at this time. The right to health contains both freedoms and entitlements, and freedoms include but not limited to the right to control one's health and the right to information. And these entitlements include the right to the underlying social determinants of health that provides equality of opportunity for people to enjoy the highest attainable standard of health. Now, this right exists alongside the rights to reproductive health, bodily integrity, safety, and security. And the right to health is a right that has to be fulfilled, not only if people meet certain criteria, but it's a right that has to be fulfilled, protected, and promoted for no other reason, but because people are human beings. And COVID-19 is showing us that even at our best as a global health community, we were never prepared. And we've seen many examples around the country, nationally, as well as in many districts and in many other countries around the world, how COVID-19 specific testing capacity, access to treatment, and a lack of consistent supply of clean water, crucial for the prevention of the virus spread, continue to be structural deficiencies. And the pandemic continues to highlight these structural fault lines, and that there is currently inadequate resourcing of community health systems, biomedical developments, and public information dissemination globally. And many health systems have failed to provide adequate supplies of personal protective equipment to healthcare professionals who are the backbone for many years of already fractured and ailing public health systems in many parts of the world, including our own country. The anxiety and the trauma that healthcare and allied healthcare professionals are experiencing at the moment is unprecedented. And the question is, for how long can they offer quality care if they themselves are experiencing rights abuses, violations in the workplace, and continued lack of urgent occupational health and mental support? Now, inequality does shape the structural challenges that are unfairly borne by individuals and unjustly borne by individuals. And through differential access to healthcare and underlying determinants of health, socioeconomic and other structural factors which interact with each other to generate and reinforce negative health outcomes that disproportionately affect certain sectors of populations. And we know that in any situation, the disproportionate negative impact affects those who are already vulnerable and finding themselves in vulnerable situations. And we must be vigilant at this time, and we've already seen in different parts of the world, to policy changes that lead to further marginalizations and violations of rights of people in vulnerable situations, and also limitations in other rights such as safe abortion access, LGBTIQ+ rights. And those people, of course, who are often neglected from health services, goods and facilities, that is women, sex workers, disabled people or people with disabilities, older persons, internally displaced people, persons in overcrowded settings and residential institutions, people in detention, of course, people experiencing homelessness. We know the statistics in South Africa, of course, migrants and refugees, which are already made vulnerable and marginalized, fellow Africans, as well as people who use drugs, LGBT and gender diverse persons. And this is just one moment, you know, that I want to take just to I suppose, underscore the very importance of ensuring that we leave no one behind. And the only way that we can make that slogan into real action is ensuring that human rights are the bedrock of all of our solutions, and that we pay attention to the rights of those people who are in vulnerable situations. And I think it's important as well at this moment in time where the global community, perhaps for the first time in a long time, has been captured simultaneously by one health issue, is that we must continue to gain a deeper understanding on the negative impact of coloniality, racism, and the oppressive structures that are reinforced by each other and that are embedded in the global health architecture, which disproportionately impact Black people, Indigenous people, and people of color communities and people of African descent all over the world. And I think even in the so-called developing countries or the global South, we do have to pay attention to the historical issues that have led certain communities to be even at more risk of COVID-19 complications and severe illness, either because of environmental damage or pollution, climate change, as well as occupational health exposure to toxins. And to date, there has been more than 50 million confirmed cases of COVID-19, with over 1.2 million deaths reported to the WHO. And this disease continues to prove more deadly than anticipated. And while the world continues to face cumulative and interconnected healthcare, economic, social, and human rights crisis that COVID-19 has unleashed. And these and many other figures only are a glimpse of the exorbitant human cost of the pandemic. And I keep saying in all of the spaces that I go to that we have to save the humans first. The economy, all of those structures and industries only survive and only exist because there are humans who are in charge, who are the labor and the intellectual property behind these institutions and industries. So we have to focus on saving the human first. And at the national and international levels, COVID-19 has brought to the fore systemic inequalities, aggravated pre-existing institutional weakness, including in health, food, and procurement systems, and highlighted a lack of access to quality, accessible, and affordable healthcare for all. And as we know, even in South Africa, the socio-economic inequality and I continue to emphasize that a global pandemic of this scale and human cost with no clear end in sight requires a concerted, principled, and courageous response, and that all efforts to prevent and treat COVID and contain COVID-19 must be based on the bedrock of human rights and international solidarity, cooperation, and assistance. And there is no room for nationalism or profitability in decision-making about access to vaccines. And unfortunately, in a very disgraceful manner, the richer countries at the World Trade Organizations have blocked South Africa and India's proposed resolution to waiver the trips and to make sure that scientific knowledge is shared widely. And we know that not just the vaccine, but also essential tests and treatments and other essential medical goods and services, as well as supplies that are at the heart of the right to the highest attainable standard of healthcare for all, continues to be non-existent or not accessible in many parts of the world. And now there's some of very important minimum core obligations for states, and the Community on Economic, Social, and Cultural Rights in General Comment 14 goes further to define what the obligations of the states are when it comes to the right to health, particularly at the national level, and as well as the Article 12 of the International Covenant on Economic and Social and Cultural Rights. And both of those speak to these minimum core obligations, which are of immediate effect. And these immediate obligations include the guarantees of non-discrimination equal treatment, as well as the obligation to take deliberate, concrete, and targeted steps towards the full realization of the right to health. And what's really important and key, this document goes further to include the preparation of a national public health strategy and a plan of action. And how many countries around the world, including in the African region, including South Africa, can really say that they were well prepared and had a national public health strategy and a plan of action for a time such as this. And in order to mitigate and contain the spread of the pandemic globally and to support national and international economic and financial recovery, it is imperative that COVID-19 vaccine becomes available. There is only one call at the moment and one call to action that we must all support, especially in South Africa. It's one country, one plan, because even within our country, the presidency and the Ministry of Health were taken to court a few weeks ago, where people wanted the ability to privately procure and provide vaccines to the private sector, which only serves less than 18% of our country. And we can see how that even our own national plan, there are still pockets of people in society who wish to create further inequity in terms of access to the vaccination by privatizing, and already we know the constraints in terms of production that we are experiencing globally. And in South Africa, there is no other call to action except that one country, one plan. And in conclusion, as we move forward to thinking of a time post-COVID, which I don't think will ever exist, we will learn to live with COVID-19, but we must adopt a collective vision for a world and communities that uphold human rights and use intersectional frameworks as a bridge to justice. And whether before, during, or after a public health crisis, or any other situation that places people in vulnerable situations, human rights to health, including sexual and reproductive health rights, must be protected as integral elements of the right of everyone to the enjoyment of the highest attainable standard of physical and mental health, and must be protected and promoted. And I join our voices on the call by the states, the United Nations, civil society organizations, and academics to prioritize access to vaccines and treatments for people, and to ensure that scientific progress benefits all in line with international human rights principles and in consideration of their centrality as a global public good. And with that, I want to thank you very much for this opportunity to offer you these opening remarks. And I will be leaving you shortly to join another UN engagement. And thank you so much and good luck with this engagement. Thank you.
Thank you very much, Dr. Mofokeng. Thank you for the insightful comments. We really appreciate your time. Now we have to let you go, but the meeting continues. I just wanted to let everyone know that this meeting is being live streamed via Facebook on the Dullah Omar Institute Facebook page. It's also being recorded, and it will be on the Dullah Omar Institute website. Secondly, I just kindly want to ask everyone to put off their microphone and allow the panelists to speak so that there's no much interruption. And thirdly, I'd like to request all the panelists when they speak to kindly put on their videos, and that's where you're the focus of this meeting at this moment. Thank you for that. So with those few comments, I'd like to invite our second panelist, Professor Alicia Yamin. She is a lecturer at Harvard Law School and senior fellow at the Petrie-Flom Center for Health Law, Policy and Biotechnology and Bioethics. Professor, you're welcome. Yes, your video is on. Good. Yes, could I please ask Diana? Yes, your video is on. Could everyone else please put off their video? Yes, we can hear you. Please go ahead.
Okay, well, first of all, thank you very much for the invitation. And I have a few remarks, but I am also happy to leave more to the discussion because I'm interested to hear what you have to say. In addition to being a lecturer on law at Harvard, I also am a senior advisor on human rights to Partners in Health, which is a large global health and social justice organization. And so I divide my time between sort of academic scholarship and advocacy. and we have been extremely involved in the People's Vaccine Campaign and advocacy around the TRIPS waiver. So I just want to start by maybe reinforcing some of the things that Dr. Mofokeng said, and then focusing a little bit on where we are now. And that is by highlighting really 3 lies about this pandemic that we have been fed globally, and then some of the insights for moving forward. So those 3 lies, in my view, are, and she alluded to some of this, that this was going to be the great leveler, right? That all people were equally going to be affected by this virus and were equally susceptible. And we now know that is absolutely not true, that social determinants and social conditions structure vulnerabilities as well as the effects of the pandemic physically. The second, and that not only has the pandemic revealed those structural injustices, way back when the Health and Human Rights Movement was founded by, among others, Dr. Jonathan Mann, he talked about HIV/AIDS as a social X-ray. And that is true, as is every epidemic and outbreak of infectious disease. But this pandemic in particular, because of its sweeping nature, because of the state of the world and the state of many countries when it struck, is not just a revealer of structural injustices and inequalities, it is an enormous exacerbator. So I am less sanguine and optimistic about what we can do to make sure no one is left behind. The second lie I think we've been fed is that philanthrocapitalists and public-private partnerships were going to save the day for the SDGs and beyond. An investment, for example, in sub-Saharan Africa, where I lived for years. I lived in Dar es Salaam and worked a lot in South Africa and taught at Pretoria, as well as in other East African countries on health rights litigation. And that, I think, has proven also to be a big hoax, a terrible lie that we are all now living with. Philanthrocapitalists like the Gates Foundation are not accountable to anybody. They can make the policy decisions they want to make. Bill Gates was very instrumental in having the world choose a route to the vaccine distribution that relied on pharmaceutical monopolies as opposed to sharing technologies and know-how across borders. And privatization of health systems has been, in my view, largely an unmitigated disaster. The third lie I think we've been fed is that, which is partly from the human rights community itself, is that global health governance would save the day. Well, we've seen that global health governance has been enfeebled, hollowed out by many of the same encroaching neoliberal policies that have taken over at national level. And in many respects, the international health regulations were quickly set aside and displaced. The WHO is not exercising the authority that we would want it to exercise. The facility that it created, which is called CTAP, which was the COVID technology access platform, was really abandoned by the WHO itself, while the other platform, which is called COVAX, which is part of the ACT-A accelerator, but COVAX was a pooled procurement mechanism for vaccines, is the one that got all the attention. And now it was foreseeable from the start that it was going to be radically inadequate, but it has now shown itself to be demonstrably inadequate in providing enough vaccines to low and middle income countries, as well as some upper income countries. Canada has appealed to COVAX to give it some of the vaccines that it's collecting. So, you know, I think that the idea that global health governance was the way to ensure human rights were realized and equitably, and there was health equity, has shown itself to be somewhat of fantasy. Really, in my view, the only thing that ever really forces change is civil society and mobilization. That can be done in conjunction with the UN system and the universal language of values that human rights represents. And I think that's very important. I think it's very important that Dr. Mofokeng spoke today and highlighted a number of those principles that the UN system has emphasized during this crisis. But we should have learned from the HIV/AIDS crisis that really what forces change are people who are unwilling to be discarded by colonialist structures of global governance that just treat them as expendable. And so really that is, I think, the big lesson. Of course, now, in COVID, as opposed to an HIV, because it's so sweeping, I think we've also learned a couple of other lessons. One is that it can't just be antiretrovirals. It can't just be one disease that we focus on in terms of HIV, in terms of building really global institutions as well as national institutions. It needs to be systems. We need to focus on health systems as universal, publicly accessible, equitably financed with pooled, pre-pooled funding and solidarity health systems. And health systems are, as Dr. Mofokeng sort of alluded to, not just technical apparatuses for the delivery of goods and services. I have been working on this for many, many years, arguing that we should understand health systems in much more the way we understand criminal justice systems, for example, as core social institutions. In my own country, in the United States, while I'm sure you've heard about Black Lives Matter and the social the social justice protests against racial violence by the police and the criminal justice system. But the truth of the matter is that more people die, more people of color die in this country because of neglect and exclusion and discrimination and punitive health policies than because of police violence. And we need to start interrogating the organization of our health systems the way we do other systems in our democracies. And I think another truth that this pandemic has brought sharply into light is that the foreign assistance paradigm that we have in the world is grossly unfit for purpose. Foreign aid reinforces coloniality and dependence in many ways, including by rich countries now calling their donations of vaccines to lower and middle income countries as aid, as foreign assistance, when they're still on patent, when they're really benefiting pharmaceutical monopolies, and therefore cutting back assistance. So I really think that now is the time, and I'm involved in some of these efforts, to rethink foreign aid in terms of global public investment in global public goods. And many of those are health related, whether it's public health infrastructure and preparedness, or things like vaccine and intellectual property know-how. And finally, I think this pandemic should cause us to also rethink some of the structural factors that have inhibited countries' ability to respond. COVID-19 struck a world shackled by austerity, by debt, by privatization that had gone on for decades, by financial deregulation. And now is the time to revisit some of those structural conditions that prevent governments from actually taking the political decisions that would give people effective enjoyment of health and other human rights in practice. And the most acute example of that is intellectual property law. Intellectual property doesn't benefit people in the North generally. I don't benefit from intellectual property. The United States has some of the highest pharmaceutical costs in the world. Intellectual property benefits a tiny percentage of very wealthy people in the global North who are involved in the pharmaceutical industry. But because of the concentration of private wealth and the power they exert over certain governments, we find ourselves in the position that we are now in. So again, this goes back to collective mobilization across global North and global South alike to highlight the fact that this situation is really not serving anybody well. We want democratic political economies where governments are responsive to the needs of people. And that's true in the United States, which is certainly can no longer call itself a highly effective example of democracy, if it ever could. And it's true in South Africa, and it's true everywhere. So I'll stop there, and I hope that I've left enough time so that there are questions and Q&A at the end. Thank you.
Thank you, Professor Yamin, for the insightful comments on something to rethink about foreign aid and public health infrastructure, as well as vaccine intellectual property rights. Thank you for that. And I'd like now to invite the next panelist, and a reminder to all participants to please put your questions on the chat function, and we'll attend to them after the panelist. The next panelist is Professor Francois Venter, Divisional Head at Ezintsha at the University of the Witwatersrand, Johannesburg. Welcome, Prof. Over to you.
Thanks, everyone. I'll keep it brief because I think the discussion is probably likely to be rich. So I'm a professor of medicine. I'm a clinician. I've been involved in antiretroviral advocacy and ethics for the last 20-odd years. And a lot of my work has revolved around policy and trying to balance public health goods and trying to strengthen the public healthcare system within South Africa, but also been working a lot in the region. So just a couple of things. I feel like in many ways the COVID-19 catastrophe has been HIV fast forwarded. The kind of fault lines it's exposed in the health systems and the societies, it's been dreadful to watch everything still so stark and so unpleasant and so outrageous at the end of all of this. And I think we're all angry about what we can see there. But I do think the parallels, the deja vu feeling I have of being in 2001 and having life-saving antiretroviral therapy only there if you're a rich country and only if you can afford it in South Africa, which meant if you had HIV, you just died. It was that simple, despite the tablets being there. And in many ways, that's what we're dealing with the vaccine. The vaccine is, all the vaccines that are available are incredibly safe and completely effective. It is a modern medical miracle how effective they actually are. And watching these debates around rich and poor and the fact that people of color are not getting vaccinated nearly as quickly as white people, and all these disparities being there are just remind me of HIV all over again. There are a couple of things I just wanted to talk about though. Is that even here in South Africa, the entitled got the vaccines first. It was people like healthcare workers. There was no discussion about were healthcare workers the most likely to get. And even if you look amongst healthcare workers in South Africa, it's the urban healthcare workers, as well as senior politicians and senior politician scientists who got the vaccine first. And the vaccine access in South Africa has been appalling, much slower than in many, many other African countries. And not a single vaccine has been procured so far from COVAX. Now, The political narrative around that is that we didn't want to be part of vaccine nationalism, when what was actually the fact was the South African government had no plan. And I'm afraid that probably in many parts of the world, you're going to find this, is that the governments didn't have a plan for dealing with procuring and distribution of the vaccines. And again, the people who suffer most are, as in this country, are going to be the poorest, the ones with the least voice. Now, there are a couple of things that the COVID thing has sort of thrown out. And I think that one of the things, I think it's really good for us to be pointing at rich nations and pointing out the hypocrisy of it reminds me of that HIV slogan, if you're not infected, you're affected. Now, the schadenfreude of this particular virus is that you can't actually hide unless you completely close your borders, turn yourselves into a New Zealand island nation. It is impossible to actually stop the virus from actually hitting your nation. But what it does expose in Africa, and I'll use South Africa as an example because it's the gross underinvestment in health. Depending which metric African countries have signed up to, they're supposed to be spending 12% of their budget. African countries and many low and middle income countries have infinite facilities to fund their military, to fund grand adventures in sports stadia and World Cups and things like that, but don't invest in their healthcare systems. So one of the questions in South Africa that just blows my mind is that people congratulating themselves that no COVID patient went unventilated. We did not run out of ventilators throughout the country except in 1 or 2 places. Every winter, we run out of ventilators prior to this winter, the 2020 winter. Nobody's questioned why we ran out of ventilators during that period of time. The underinvestment in health in South Africa, in the USA, in the UK, is something that needs to be challenged going forward. And I think that this false dichotomy the economy versus health has been seen generating capacity. The fact that I see you probably lost me there for a moment.
Yes,
but the
please
fact
go
that,
on. Yes.
Sorry, I'm back. The fact that African countries, or lots of low and middle income countries, do not invest in research. That took the Gates Foundations and the NIHs and American pharmaceutical companies and other pharma companies to do that investment that didn't come from our own people and our own fiscus, makes us reliant on all these other forces within our countries and leads to these deep divisions that we see at the moment. So I do think that we need to be pointing fingers at rich countries, but we do need to be pointing fingers, hard fingers, at our own countries for what they have done to the health systems for decades now, where they haven't prioritized the people of their countries. I'll leave it at that.
Thank you, Prof. Thank you for your insightful comments on what COVID has exposed in terms of public health system investment. Thank you for that. We now come to the part where we have the open discussion, and I'd like to invite, there are a few questions that have been posted on the chat box. So I'd like to invite Professor Venter and Professor Alicia Yamin to have a look at that. I also want to read out one of the big questions that came through. Just give me a minute, I'm just going through them. A question from Kolesa Weso. What are your thoughts on possible corruption threats around vaccines in South Africa? And how, in your opinion, does this affect human rights in South Africa? I suppose that is to Professor Venter. Please go ahead.
I guess it's the concerns we all have, is that money will be rediverted. The one thing the South African state has demonstrated is superb efficiency in executing corruption around the PPE scandals. And I think that, we weren't able to distribute food parcels. Only things we were really good at was deploying the police and the army to the streets and then fleecing the state while the tender PPE systems happen. So again, it is a concern, is that people are going to not get the vaccines, or the vaccines are going to be super expensive or poorly distributed because of corruption. And I think there's a complete lack of trust in government's ability to actually distribute the system within the system that is available to it now. So I am feeling I'm angry, and I'm also very bleak about the corruption systems. But the nice thing about it is that the thing South Africa has, which many other African countries doesn't have, is it does have really good investigative journalists who tend to be able to uncover these things very, at least somewhat, and have over the last the year been instrumental in uncovering the scandals that have come to us. So I share your fear.
Thank you for that response. I can't see any hands up for the questions. I asked people to post questions on the chat function. I only saw one question, and I can't see any hand up. Could anyone else? Kelvin Johnson, please go ahead. If you could
Thank you
put on
very
your...
much. Thank you very much, Gladys. It's quite insightful, and it's quite interesting to listen to the experts. I'm thinking about my own country, where the variance almost comes up on a daily basis with various mutations. So will we ever have a vaccine where the efficacy level will at least be 98 or even higher percent, and deal with the virus on how it's supposed to deal? Because there is new variants coming, especially from South Africa, and everybody is talking about this variant. So will we ever have a vaccine available where the efficacy level can be 98 or even higher? Thank you very much.
I'm happy to take a first stab at that question.
Please go ahead.
So as Professor Venter suggested, the vaccines that have been created are quite remarkable. The degree of efficacy that we have seen is much higher than in many of the vaccines we use regularly in our childhood vaccination programs around the world. And it wasn't expected that there would be vaccines that would reach the levels of efficacy, say, of the Moderna or Pfizer-BioNTech vaccine. And Novavax is also showing extreme levels of efficacy. I think the question of variance actually goes... The question of variance, to me, suggests that we may need to think about vaccines possibly in the way we think about the flu vaccine as an annual vaccine, or a biannual vaccine where you need a booster of different things. But that scenario where it's not just one shot now makes the governance of this crisis even more critical. So COVAX was always understood as an emergency response with the pooling of these vaccines right now. But if this is something that is going to go on and we're going to need to vaccinate in future, then the vaccine apartheid, as we call it in the United States, is really even more of an unbelievable injustice. And also, as others have pointed out, a detriment to the global economy. So I think the variants are likely to play out in that regard, not that we get a 98%.
So Kelvin, maybe to paraphrase Alicia, just one of the two scenarios I look at is what Alicia's talking about is a nightmare scenario. It means vaccinating every year. We are going to have to restart, or every 2 or 3 years. It means no old person's ever going to be safe, because you never know when that variant's going to come through. It is going to require a complete reformulation of our society, that every adult is going to need to get vaccinated, possibly every 2 or 3 years, possibly every year, like we do with the flu vaccine. But what we understand from the virology at the moment is that is extremely, extremely unlikely. I think what's much more likely is you're going to get infected really severely once. And you can either do that with the protection of the vaccine, which are all exactly the same. You can't actually compare the vaccines head to head. They're all, the 5 major vaccines protect you 100% from hospitalization and from death. They're all exactly the same. They have different variation in terms of protecting you from infection, but I take a vaccine to keep out of hospital, not to stop a sore throat. So at this point, I think the more realistic thing is that to get vaccinated, we need to get the vulnerable vaccinated as quickly as humanly possible. And everybody else that we can, so that when you get your first infection, which is going to come, this virus is just going to circulate and circulate and circulate. And it's not just the South African variant. There's a Pofadder variant. There's a Delhi variant. There's a Melbourne variant. There are thousands of variants out there. Some of them are more infectious than others. The one that originated in the UK seems to be the most fit, and it seems to be taking over. So those are the scenarios we're looking at the moment. Is that there are 5 other coronaviruses, and they just circulate. You get it as a 3-year-old when your immune system can deal with anything, and you get it every couple of years, and that almost revaccinates you as you go along. So I think that's the much more likely scenario. That the virologists are settling down at the moment. So that gives me a lot of hope. The alternative that you're describing and that Alicia's pointing to is an Armageddon scenario, which will require complete reorganization of our societies. And no other virus has behaved in quite the same way. So I'm hoping we can come down on that side.
Well, so I didn't mean to suggest that that's definite or that everybody would need to be revaccinated, but I also think that modeling needs to take into account that it depends on human behavior.
So if we're right in the second scenario, the kind of auto-vax is eventually you're going to get it. It doesn't, unless you live behind a closed wall, you're eventually going to come into contact with somebody with one of the circulating coronaviruses. And it's whether you get that first infection vaccinated or unvaccinated, that you roll that dice. And that is a 6-sided dice. If you're 50 years old, if you roll a 6, you're going to end up in the hospital or on a ventilator or dead. If you roll a 5, you're going to be very, very sick. And if you throw a 4, you're going to get long COVID. And if you throw 1, 2, or 3, you'll be okay. Once you're vaccinated, that turns into a 20,000-sided dice that if you're very, very unlikely to grade.
No, I agree with that.
I think that's kind of the way I think that we're trying to pitch it, which is great because it gives us hope that very soon we'll be back to normal. What happens though is you don't want your granny, your diabetic aunt, your cousin with cancer to be rolling that dice at the moment when there's so much circulating virus. You want them to be rolling that dice when they're vaccinated.
Thank you, Prof. I think I want to add this panel to that. A question from Aaron, who says he's 75 and he doesn't want to have the vaccine, and he already had the COVID and he had no breathing problems at all and no symptoms. Would he have to be forced to have a vaccine? That's the question from Aaron.
So yes, is the short answer, I think, is that all the data suggests that, Aaron, if you've had it, you're one of the lucky ones because you probably have a great deal of protection. The vaccine is just going to top you up.
Sorry. There's another question from Tim.
Can I come in?
Yes, please go ahead.
All
go
right.
ahead, Aaron. And then we'll have Tim.
I'm not a conspiracy theorist, but I have a lot of friends who never vaccinated any of their children and just saw them through most of the diseases that, like measles and mumps and things, and that these kids are very healthy kids. I'm very geared towards just taking on the thing and fighting it inside my body, and I would like to do that and have myself registered as therefore what is the dice situation for me if I go through it and I survive completely, which I've already done, and I'm happy to do it again. You gave a dice situation there as 1, 2, 3 to 6. Now, when you've got the vaccine, now tell me what the dice situation is for me.
I need to know how old you are. Do you have diabetes? Are you overweight?
No, I'm not. I'm not. That's the point. The reason
which are you?
I am a very healthy living person who's geared towards a strong immune system. I still can cycle 100 kilometers. My morning pulse rate is 45. My blood pressure is 110/60 in the morning. I'm looking after my own immune system, and I want to have the right to do that without being forced to vaccinate.
I'm not suggesting, I didn't suggest for a moment you get forced to vaccinate, Aaron, and I don't think that's a good approach.
No, I'm asking. Yeah.
What I'm saying scientifically is if that second scenario is correct, is eventually you're going to get it and you're going to roll that dice. I think where I would differ, because I kind of was with you until the long COVID came out. I'm 51, I have no comorbidities, I'm very healthy. Yeah, I thought, well, what's a really bad flu? Now, firstly, it's much worse than flu. You know, you're not going to end up in bed for 3 or 4 days. You are going to be hammered. It's also consequences that we're only learning about now, the long COVID consequences on your brain, on your heart, on your kidneys, on your liver, a whole range of stuff that we're only sort of seeing now. Now, I know lots of people like you who are unbelievably healthy, who got COVID, who are still short of breath 3-4 months later. Now, you are going to take that gamble. You know, if you don't get the vaccine, and I'm right about the circulating virus, eventually you're going to get it, and we'll find out, you know, how you rolled that dice. And that certainly is your right. I certainly wouldn't suggest vaccinating you. I, however, am encouraging everybody I know to get the vaccine as quickly as humanly possible, just based on long COVID. Even if it didn't have the small
We've lost
Prof there.
Can you hear me?
chance of
Yes,
dying. How old are you?
He's back. Please go ahead.
Me?
Aaron, how old are you? Yes.
Yeah, I'm 75, but I'm probably going to live to 101 easily.
So your mortality, if you get COVID, Aaron, is probably at least 5%. Now that's 1 in 20. If I knew there was a 1 in 20 chance of me dying if I got into a car, and I knew I had to get into that car, I would do everything in my power not to get into that car. So I accept the fact that you're incredibly healthy and you probably have a much better chance than the average 75-year-old, but you're still not completely immune to the effects of this virus. And there's increasing data that you also would be more prone to getting long COVID. So if you,
my father's... Francois, is I had absolutely no breathing problems. It's like I test all my parameters once a week. I even do breath holding. During the 4 weeks, I was buggered. I was totally out. My muscles were aching. And so I was bad, but I had no breathing. I hold my breath, and in those 2 of the weeks that I was holding my breath, I was holding it 10 seconds longer than average, not shorter. And now afterwards, I had a bubbling in my body that went up and up and up from my abdomen through my brain. I thought I was going to faint, and when that was finished, I was totally okay. Since then, which is the end of December, I've been cycling. I climbed up Lion's Head with some people. I do not believe I'm going to have anything long term. So I just want to.
Sorry, Aaron. I'm not a clinician. I'm a lawyer, and I know something about the law in the United States as well as international law. So the other thing to think about is that if you are not vaccinated, it's conceivable, I mean, you've had it, but it's also conceivable that you could transmit it to others. And so there's a strong public policy argument to be made that, which is why we are going to increasingly see places of employment, airlines, travel restrictions, unless you can demonstrate that you have been vaccinated. And so that is also something to consider. I think one of the things coming out of this pandemic is how we care for and regard the pain of others, not just ourselves.
No, absolutely. Look, I totally understand that, but is the science being done that tells me what the difference is in my infectability compared to somebody who's been vaccinated? Because I've gone through it. Surely, don't I get on par with these with the vaccinated people? Yeah. And is that investigated by science?
Thank you, Aaron, so much for that engagement. I want to take it a little forward because there are other people who raised their hands and they want to contribute to this. I'd like Tim Hodgson to please speak. He had his hand up.
Hi, thanks, Gladys. The question is most directly for Alicia, and thanks all for your presentations. Given the way that it seems to be going on the WTO with the TRIPS waiver and richer countries blocking it, is there an argument to be made in international human rights law that states are under an obligation to support a waiver of that nature? And if so, do you think it could be litigated in domestic courts like in South Africa or in regional courts? Thank you.
So there's absolutely an argument to be made under international human rights law. There are a number of different general comments on the social dimensions of intellectual property and interpretations of states' extraterritorial obligations to rein in transnational corporations over which they have effective control. So there's absolutely an argument to be made, and I think not just under international human rights law, but also under differing interpretations of intellectual property and antitrust law. Whether it can be litigated, I can imagine that it could be litigated in some, probably where the in the countries that are not already advocating for the TRIPS waiver, right? The countries that are basically being dictated to by the pharma monopolies. That is a long process. That's one of the problems with our traditional toolkit of human rights strategies. You know, I think one of the things that is going on now, in which Partners in Health is very deeply involved, is the effort to really bring to bear evidence of what the effects of not acceding to the TRIPS waiver are going to be, and using that to pressure governments in the North, including the United States, and the more expansive use of the Defense Production Act than has so far been announced. And I think that, again, going back to HIV, that was somewhat successful. If you look back to the Pharmaceutical Manufacturers Association case, it was really a matter of bringing to bear the pressure of civil society to shame those 38 or so pharmaceutical companies that they were creating a swath of death and suffering. And so I think that in the near term is going to be the most effective. And I'm not saying it's likely to be effective, because it's looking like a small cabal of rich countries are really digging in their feet. And it may also be that the new Director General of the World Trade Organization, who may have wanted to helpfully propose this third way, has ended up really sucking a lot of the energy out of the waiver proposal itself. So could it be litigated? Yes, theoretically. Is that going to help people in the short term? I'm not so sure.
Thank you. Thank you for that. If I may read another question from Mallory's and Utaleman. What would Alicia and Francois identify as the key pillar of national and international vaccine plans, and hence, beyond the obvious already established vehicle? I think this person is trying to refer to the mishmash advisories and PowerPoint presentations on how to roll out the vaccine. What should we look out in terms of human rights provisions and clinical aspects? What should be included in it, in this plan?
I just think you need to keep your beady eyes on speed and who's being left out. You have to get the whole adult population vaccinated as quickly as humanly possible. And using South Africa as an example, we have erred on the side of safety, and I'd argue that that's been done in Europe as well, where instead of procuring as many vaccines as possible and vaccinating as quickly as possible, that hasn't happened. I'm reminded again of the ARV sort of programs where there was so much attention to safety that lots and lots of people died because we were twiddling our thumbs, worrying about whether it should be 4 or 5 attendance at adherence meetings and things, and getting the absolutely perfect regimen when people were dying of AIDS around us. And again, speed here is absolutely important. Getting it absolutely perfect is not as important. If we are going to get enough South Africans vaccinated, for instance, or enough Africans before the next variant hits us, or the next third wave, or whatever that looks like, we're not quite sure yet. We really need to be moving faster. There's certain countries which I think are leading from the front, and Rwanda has been very impressive, vaccinating 70,000 people in a day. It's taken 4 weeks for South Africa to vaccinate 140,000 people, a much bigger country with far more resources. So paying attention to speed, and paying attention, as they are doing in the US, is who's not being vaccinated and why. And that's, as usual, it's poor people, it's Black people, you know, looking at those fault lines and quickly pivoting your program to adapt.
So I would agree with that. First of all, going back to a comment that was made earlier, South Africa is far from the only country where we have seen the vaccine rollout plagued with corruption and misdirection, right? In the United States, we have seen the same thing, concierge, medical clinics giving it out, tourists flying up from Latin America to get it in the state of Florida, all kinds of corruption, and the same has been true in any number of countries throughout Latin America, etc. So that's something to be kept in mind, and I think it's to be expected to some extent because of the centralized control over this and the extreme power given to the executive branch and the lack of oversight, right? I would emphasize that in the vaccine allocation and the ethics of it, people who are affected from marginalized communities need to have a seat at the table. So in Partners in Health, we've worked a lot with incarcerated populations, with the most marginalized homeless populations and marginalized populations within this country, and overwhelmingly people of color, undocumented immigrants, persons living with disabilities who have a much, much higher risk of mortality if they get COVID. So those kind of marginalized populations need to have a seat at the table and understand why decisions are being made in the way they're being made.
Thank you. Thank you for that response. Thokozile Madonko, you had your hand up. Could you go ahead, ask your question? Toko?
Hi, I'm here. Thanks. It was really just in response to Alicia's point about affirming, and I think Francois and Alicia have spoken about this, is that beyond the politics of accessing these vaccines and the sort of predatory nature of pharmaceutical companies around intellectual property rights and that kind of, those kinds of issues, there is the more fundamental question about how we see each other and how we engage each other and understand public health and how we understand, I'm sorry, I came in late, so if I missed a speaker, I apologize, that to affirm that we look after ourselves in ways that help us to look after others. And so I almost want to affirm one of the arguments that is coming through now quite strongly in the kind of the economic justice conversations, is that are we making decisions based on care? And if you really care about the people living in and around you, then you would get the vaccine, because that's what the science tells us vaccines do. They help us to take action to take care of others. It's the same logic as not drinking and driving. It's the same logic as making sure children get food when they go to school, because we recognize the care involved in being each other's keeper, to use a kind of cliche term. So, and then to bring that back to the political is that we then fight for access to this treatment because we care about each other, because we care about the nature in which we live and work and love. And so we should have access to the same amount of vaccines as any other country if we have a good internationalist perspective on the right to health. So I just wanted to go, yay, for both, understanding our individual comorbidities. And yes, that's all important. But at the end of the day, I might be as healthy as anybody, but I can't know about the person sitting next to me on the bus. That I cannot know. And so I have a duty to protect that person. And we can do that.
So I think that was, sorry. I think that was absolutely beautiful and eloquent. And I completely 100,000% endorse that and agree. I do think to some extent we find ourselves in this dilemma because we've constructed societies that sort of systematically allow us to disregard the other. And you know, those of you in South Africa know this better than any. You know, apartheid was a system that was absolutely designed to otherize, right, in every way, from micro interactions to organization of social systems to macro economic and political levels. But in democracy, the extreme inequalities of income, whether in South Africa or the United States or many other countries around the region, does much of that work. So wealthy people who get to work at home, who get to isolate, who have servants who they can sometimes have COVID tested before they come into the house, who are not suffering because of this, and who don't rely on public services. I mean, now the wealthy are buying their way out of public security services, of public health services, of public education services. And that means that what's left for middle income or low income people is not such a concern to them, that they can easily sort of turn away. They can live in this Zoom environment and get the vaccine before anybody else gets it, and get priority and access to care, and not do exactly what, I'm sorry, I can't pronounce your name, just said, which I think is the fundamental idea behind human rights, that we share a common humanity and we need to care about each other.
Thank you so much. Thank you so much for those comments. I think I'll give Professor Venter the opportunity to wrap up, and then because we've come up to the end of the meeting.
Yeah, thanks, Toko.
Please go ahead.
Comments. Thanks for those comments, Toko. Just to wrap up, one of the things that I think this community needs to understand, there is a dream scenario, which is that we're almost back to normal next year. That there's been 4 or 5 waves, there's been enough vaccination to give us the magical herd immunity, and it's clear that the vaccines give us long-standing immunity, which is actually increasingly what I think scientifically is coming. We need to make the human rights strides urgently now, because the virus might be yesterday's news in 4 or 5 years' time, where we're cleaning up the economic mess and the disaster that's happened in the healthcare system in terms of the interruption of services. So all I'm saying is just try to use these opportunities for taking forward the human rights as quickly, whatever the area they are. The other second thing is try and balance access to vaccines at a reasonable price with the speed of vaccination. If we do not get vaccines to people soon in South Africa and probably in the region, judging by the epidemiology, the 3rd, 4th waves will have rendered it, will have taken out the most vulnerable people in those processes. So if the most important thing we need to do is to get our governments to operate with speed and to put pressure on the international agencies and everybody else who's working on this project to get the vaccines across the borders and into the arms of the people who need them.
Thank you, Prof. Thank you so much for your insightful comments. I'd like to invite my colleague, Professor Powell, to give the closing remarks. Derek, Professor Powell, are you there?
Gladys, thank you very much, and thank you to all of the panelists for wonderful presentations and insights. It's hard to believe that it's a year on already. I recall when the pandemic first broke, my colleague Ebenezer and I thought, you know, what can we do in this space? What needs to be done? And I think we were both at a NYU webinar, one of the very early webinars, where one of the presenters said that we're going to face 2 pandemics, the health and the governance pandemic. And the governance pandemic was likely to be with us for some time. And what we thought we would do was to create a platform which would allow us to look at the range of issues coming out of the pandemic as they unfolded, and to try and do 2 things on this platform. One was to provide an all-in forum which could bring together scholars, civil society, government practitioners, funders, and the like, ordinary people, to use it as a kind of therapy in a way, but also in a way that we could think through the problems as they were unfolding and take stock and have a record of these. And secondly, we wanted it to be a global south, global north initiative. We felt that this was tremendously important to build this dialogue across borders because it was a global pandemic. And you've really assisted us here to do this on a very special occasion. Unfortunately, one that we wouldn't call an anniversary unless we had to acknowledge the fact of the pandemic, and that is the one pandemic. And our institution is running a number of events and of those events. So there will be several others from colleague programs that will talk into the space going forward. To pull out one thing and perhaps just leave it, and perhaps it's something we can look at going forward, and that is a deep concern that seems to be emerging in some quarters going forward about the potential securitization of health and how health security, population management, and information surveillance technology coincide. There's a whole area there that I think is an area that we possibly need to look at a little bit more closely going forward. But that is for the future. And for now, I just want to thank all of the panelists very much for taking the time and the interest and sharing your thoughts with us and your insights and experience. Thank you to the audience as well. Without you, we couldn't have these webinars. And there are some old familiar faces already after a year, and we're very appreciative of the loyal following that we have and the valuable contributions that people make into this platform. It enriches the experience for everyone. And thank you also to Gladys and the team behind the scenes that organizes these things. We have a wonderful communications team, Kay, who's the head of our communications program. She does a huge amount of work for us to get these messages out and make these platforms run as well as they do. So thank you to everyone. And please do look out for the next webinar. It's going to be an interesting follow-on from the Next Generation Constitutionalism series, where we've been looking at a range of issues around how constitutional law talks to the problems of our time. And the next one will be on a constitution for nature, where we will look at natural thresholds in the environment with an environmental scientist. And we will begin to start linking the debate around the environment and nature to these issues of health management, healthcare, social justice, and the like, because at the end of the day, they're all integrated, and we need to look at it from these perspectives too. So thanks very much to all, and we hope that you will continue to support this platform as we bring it to you. Thank you, Gladys.
Thank you, everyone. And we now come to the end of this conversation. We really appreciate your time. Bye-bye.
Take care, everyone.
Bye. Thank you. Bye-bye.
Bye, 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 Prof Venter. Bye-bye.
Bye.
Thanks, Gladys.
Thank you.
Bye-bye.
Bye.